All right, I suggest we get started. It's a few minutes past 3, and first and foremost, thank you for so many has taken the time here in the afternoon to sign up for this webinar where we discussed about applied AI for healthcare, and maybe just a quick introduction about human bytes. I see quite a number of new faces here online. We are a Nordic distributor of AI for healthcare. We are working across a number of different specialties, where today we'll talk about ophthalmology. But just to give a few use cases with the AI we have implemented with good effect here in the Nordic countries. Breast cancer in 2 regions in Denmark, where they published just before summer in radiology some quite amazing results, both on workload reduction and fewer recalls and false positive, but especially a significant increase in cancer detection, especially small invasive cancer. Fracture detection also running 3 sites here in Denmark, with a good effect on the waiting time especially, but also the diagnostic has significantly improved. Cancer treatment with radiotherapy in Norway and also in Sweden, where we have this auto-contouring organs at risk that takes a child from 1 to 2 hours down to just a few minutes. And just the last few cases, I just want to highlight patient monitoring, the intelligent bed with the continuous monitoring radar, and that they can reduce critical complication at the general ward and automate the early warning scores. Digital pathology, also very active in this field. And then today we'll talk about the eye screening. The last slide here, just for me, is just a small advertise from our Human Bytes AI Academy. We have one upcoming seminar here within radiation oncology with Nikos, the CEO of Therapanacea in France, who will tell some about the latest advances within radiotherapy. And to the right, it's very small, but some of our historic webinars that you can find in more details on LinkedIn, including a recorded version. This session will also be recorded and be uploaded. So if you want it afterwards, we can share the link. If you have any questions along the way, please ask them in the chat, and then we'll have a few minutes at the end just to go through a question that may come. But the next half an hour is really zooming in on AI for eye screening, where we have so fortunate that Chaitanya from INOC in California is very early up in the morning here to give us a quick rundown of the perspectives within AI for eye screening. So with no further ado, I'll just hand it over to you and allow you to introduce yourself and please just take us through your content.
Thank you, Ulrik. Very nice to meet you all. Thank you for making time in the middle of your day. Very good afternoon. Let me just share my screen and get started. All right, I'd like to speak to all of you about how we want to use AI to help detect multiple disease conditions using retinal imaging. First, a little bit of background about where I work. We're from INOC. We're a global AI digital health company that's headquartered at Los Angeles, California. We were founded around 14 years back, and the technology that we have developed has been adopted in over 27 countries across 5 continents. We originally started with the help of NIH grants. So we had these projects that we had in mind for which we got funds from NIH, and that is how we were born. And we've raised some investment for our prospective clinical trials of it. Our mission is to lead the world to a new diagnostic platform using retinal imaging and AI. Why retina? Why retinal imaging? Retina is a fascinating organ. It's one of the few, it's the only organ where you can non-invasively image microvasculature. And health of microvasculature is indicative of many systemic conditions. Embryonically, retina is part of the brain, and therefore you get a lot of biomarkers about nervous system as well. So that gives us a place with a lot of, which is rich with biomarkers, not only for sight-threatening conditions like diabetic retinopathy, glaucoma, macular degeneration, and others, but also systemic conditions like cardiovascular disease, hypertension, Alzheimer's, and many more. So we believe that a combination of retinal imaging with AI that's been designed and built the right way is definitely set to be a diagnostic platform of tomorrow. What are some of the advantages that such a platform might entail? There is ease of capture of these fundus images using the standard fundus camera. No dilation is typically needed, and you get an actionable and almost instantaneous report um, using this platform on various different conditions, not only about uh, sight-threatening conditions that might be present, but also systemic conditions, and all done with non-invasive eye imaging. So one question that we could probably, from a very general way, in how many ways can AI help healthcare providers? There is spell check AI, which is assistive AI, which works like your lane assist in your vehicle, right? So it checks for your work for errors. And if there's a spelling error, if there is annotation error, then it says, hey, it's wrong. Maybe take a second look. There can be autonomous AI where your routine work can simply be automated. These are essentially the robots of the world, right? I mean, so, and finally, superpower AI. Now, this lets you do things that otherwise would not be possible or would involve a lot of effort. Makes it a lot more easier to look for biomarkers, look for changes that otherwise wouldn't be possible. Inox AI's offerings, all under a single united platform, have these three flavors as well. We have iScreen, which is spell check for eye screening programs. We have iArt, which is the eye screening robot for primary care providers. And finally, we're working on iMark, which we believe will give the superpower to eye care professionals. Now, the number of diseases that, these diseases that we're looking at that are, again, based on AI analysis of retinal images have significant impact. I've listed a few of these diseases, and the at-risk population of these disease runs into hundreds of millions, if not billions, for cardiovascular and stroke risk. So these are extremely large populations and worldwide that are at risk. And so the only way to regularly screen such a population would be to use AI. I want to focus on blinding eye disease. That's what we started with. Diabetic retinopathy was the lowest hanging fruit for us to start with initially. We added glaucoma and macular degeneration conditions as well. Now, these three conditions are largely asymptomatic. But if they are identified, if their onset can be, is identified early enough, then with timely treatment or intervention or management, then these diseases progression could be delayed, their onset could be delayed, uh, and a disease could be managed at in a much better way. So there is a need for regular eye exams. If one looks at traditional testing approaches to do this, they're simply not scalable. One, because of what I mentioned, that there is a growing at-risk population. So it's a really large population that one has to address. Now, if we zoom in and look at the current methods that get used, there is the in-office ophthalmoscopy, or there could be fundus reading with human reading, fundus imaging by human experts. Now, both these have challenges of their own. Now, in-office ophthalmoscopy comes with scheduling difficulty. It could be hard to get an appointment with the ophthalmologist. It can be time-consuming, generally requires a dilated eye, and this is not always something that patient likes. It can be subject to human misses. Remember, the ophthalmologist is trying to look for a really small pinprick at times. It's like I was described. This is how it was described to me. It's like looking for a red tennis ball while shining a flashlight in a dark room at times, and it can be expensive as well. There was a study by actually a group at Oslo, UNICEF Oslo, which put this price at over $150 per visit. Now, and the turnaround time, it's 30 minutes. Now, if you go to fundus imaging with human reading, where human experts grade, the output is generally, it's hard to provide these results back in real time. And you need to have expert reading staff, and there is operational strain. There are few organizations that have pulled it off, but then they still feel this operational strain, NHS England being one. And the benefit of providing this real-time feedback are definitely, something that you cannot get with this. So with iArt, we are the first autonomous AI solution with Class 2B MDR certification for DR, AMD, and glaucoma. Any physician can prescribe this test to a patient. So it can be endocrinologist, for instance. It can be a primary care physician. There is a simple imaging process, which gets done typically in minutes. It doesn't require a healthcare provider. It can be a technician. These images are then uploaded to our analysis cloud, and results are available within 10 seconds. With EMR, EHR integration, this can provide a almost seamless clinical workflow at a lot of organizations. Here is a zoomed in view of the report. We provide eye level results. So we say if the patient has diabetic retinopathy as reported on the ICDR scale. So it's not just should the patient be referred or not. Our certification allows us to output the actual DR severity scale level as well on the ICDR scale. We also report an AMD, which is intermediate AMD or late AMD kind of output that is based on the Beckman scale. And finally, glaucomatous optic nerve damage that's based on color fundus images markers that's been used for glaucoma. In addition, there is a thumbnail of images, additional information, and even diagnosis codes for DR, ICD-10 diagnosis codes are available. So if the kind of, this is the recommended referral workflow that gets used typically. If a sight-threatening condition is identified by IART, then the patient is referred with preferential scheduling, if possible. If it is a referable condition, for instance, moderate NPDR on the ICDR scale without diabetic macular edema, then that would be just a plain referral, maybe 3 to 6 months. And if there is no referral condition, then the patient can be asked to return for imaging within 12 months. These numbers here for referral times and all that are to be based per the recommendation of local medical organizations and associations, of course. These are recommendations that we have per the AAO here, but these can change per what local associations, country-specific associations mention. And that's all configurable, of course. I want to take some time and talk about the work that we did to validate the technology. So how do we know that a technology is safe to use? So one thing is it needs to be based on really good science. So the foundation must be really good. Once you have that, it needs to be tested. Of course, tests can go multiple ways, as our friend here found out. What do I mean by proper testing? We need studies that generalize. We maybe need tests that are not conducted by folks who develop technology, meaning, the tests that I'll report that are completely independent from independent organizations from INEC. The way subjects get selected for these tests, they must be representative of the population that's of interest. The ground truth clinical reference standard that is used to compare should make sense. And finally, the size of the study. So we do not want to be introducing systematic errors during these studies, which might lead to incorrect determination of safety and effectiveness. IARC validation is definitely generalizable. Here I'm reporting 4 studies that were independently done on large number of consecutive patients against rigorous ground truth. There was the US Veterans Affairs head-to-head comparison of 7 different diabetic retinopathy screening algorithms that was done on over 23,000 patients. We were the only technology that was statistically indistinguishable from the human grader and had 100% sensitivity for moderate or severe NPDR or PDR. Likewise, in other studies, again done large studies done at UK NHS, IART has been on the top of the studies as well. As these slides will be shared, I'll invite you to maybe look through these publications for more details. We also have a prospective clinical study that was done in 15 different US centers on 942 patients. IART results were based on undilated 2-field fundus images. These images were captured by novice operators. These results were then compared against the ETDRS reference standard, for which stereoscopic 4-wide field fundus images were acquired post-dilation. These images were graded by multiple expert graders from Wisconsin Reading Center, which is the place where the ETDRS grading standard was built. And then adjudicated grade was the adjudication of the grade between these multiple expert graders was considered as the gold standard. And that is what IART was compared against. Against such a gold standard, IART ended up with sensitivity of over 96% and specificity of 88% for more than mild DR, which is moderate NPDR or worse on the ICDR scale, or could be presence of diabetic macular edema as well. And for vision-threatening DR, the numbers were spectacular as well. And here it is severe NPDR or PDR or diabetic macular edema. That's what you would define as vision-threatening DR. So from all these studies, we believe that IART is definitely safe and effective. And we also believe that it's probably one of the most validated AI technologies out there for DR screening. One of the sub-studies that we did, we also looked at, we compared our performance against dilated ophthalmoscopy. So a subset of patients over, I believe, a large subset of patients in the previous study that I mentioned, well, they also underwent dilated ophthalmoscopy, and IART's performance was compared against dilated ophthalmoscopy. As you can see, IART had more than 3 times the sensitivity. It's a hard ask to ask, ophthalmologists to look for what might be really small dot hemorrhages or really small hemorrhages with pretty quickly. So sensitivity can suffer, and that is what we saw in this study as well. We have been compared against other AI technologies. This has been published across multiple independent studies. There was a health technology assessment that was done by UK National Screening Committee, where IART was the only AI technology that's been approved by the UK government for live clinical use. We ended up being on the top on the US Veterans Affairs study that was done in 2021. Also on top on the UK NHS study that was done in 2017. Both these studies had over 20,000 patients. Switching gears, let me talk to you about some usage. We have done over 250,000 screening visits till date. This has led to identification of over 30,000 patients with sight-threatening conditions. And this is over 20 countries and 5 continents. Let me just pick an example of Armenia. We work there with Armenia Eye Care Project. And it's a nationwide screening program where images are captured using these fundus cameras that go around maybe in vans, trucks, and then these images are, of course, sent to us, and we send them back immediate results. And this has led to over 20,000 patients being screened till date. This work was recognized by WHO and also the World Diabetes Foundation. Finally, I want to leave you with the way we are thinking about predictive biomarkers based on retinal imaging. Right now, we have IART that's been approved for automated DR, AMD, and glaucoma screening. We have with full vertical automation. By that, I mean integration to EHR integration with cameras, which we have already done, and with additional disease conditions such as stroke detection or Alzheimer's identification, or maybe flagging kidney issues. We hope to build end-to-end automated screening for multiple conditions. That's that report that I showed you earlier. That is not only with AMD, glaucoma, and DIA, but also cardiovascular conditions and many other systemic conditions. Once we have that, what we are more excited about is our current research work where we are comparing imaging from multiple longitudinal visits, and we align these images, we look for changes, we characterize these changes, and then we hope to build systems that can predict what current clinical measurements can do. This could be identifying patients who are at more risk for progressing into severe forms of the disease at a early form. For instance, let's say we would say, okay, here is a cohort of patients where we would think diabetic retinopathy would progress quickly, and maybe therefore they need more active management. Maybe they should be screened more often, and things of that. So that's what we hope to build. That is all I had. Thank you. I'm open for questions at this point of time. Let me stop sharing.
Yeah, thank you, Chaitanya, for a good presentation and explaining, how the strong data behind it and the evidence and also the vision for the future. If any question, please raise a hand or post them in the chat, and we can take them here. But maybe just while we see if anyone's coming in, allow me to have a few. Now you just started to begin with the fundus imaging. Why not the OCT or wide field, and what are your perspectives around that?
That's a great question. So we started off with the color fundus images primarily because of its accessibility. It is something that's very accessible at primary care clinics, which is where we believe most of the screening should be done. That said, we think OCT and ultrawide field images is something that is definitely useful, and that is something that we definitely are working on as well. So ultrawide field images gives you an ability to look at the almost up to 200 degrees field of view of the retina, which allows us to look for biomarkers that might be interesting. There have been studies that have said that peripheral lesions might be indicative of more severe forms of the disease. And there is work that's going towards understanding more about these peripheral lesions, so to say. With OCT, now the field of view is not as high as even a color fundus images. So it's more of an in-depth view of really a localized location most of the time. And the way we think OCT would be useful is start with the ultrawide field imaging or a color fundus imaging, identify locations that are of interest, and then do a in-depth analysis of those regions with OCT. And AI definitely has a role to play in those.
All right, thanks. And another question here. Now you had a long list with a lot of countries. You also show study with a very high sensitivity and specificity, but the robustness is a theme when we talk about AI. So do you see any significant difference in performance across the different population you're active in?
Sure. That's a great question. So, I went ahead and analyzed our referral rates across different countries. And that can definitely change, depend on the kind of patient cohort that you know that is presented in front of IR, right? At places where there has been a well-run eye screening program, we do not expect a whole lot of patients with vision-threatening conditions, and that's what I see in the data as well. So we are being used in Spain, and the referral rates there by IART are in the tune of about 20-21%. And that's the places that it's getting used are essentially places where there has been eye screening program, and then this was IART was bought to automate those. Now, on the other side, there are countries where there was not much screening originally, and this primarily maybe because of resource issues. And IARC was gotten as the initial and the primary screening tool. There, we unfortunately end up finding that most of there is a good percentage of patients who end up with vision-threatening conditions and all that. Armenia is a case that I would maybe mention. We see referral rates over 30-35%, and sometimes even more, depending on um, depending on what region, are they rural, are they urban, right? So I guess the answer would be, depending on the region, depending on how adhering they have been to eye screening prior, the referral rates that you see would that is the referral rate that you would see over time. We would expect it to drop off, of course. uh, you know we don't expect a lot of these sight
All right,
limited conditions to sustain.
great. And then a question from Jesper here. IR is indicated for some Canon and Topcon cameras. What about the other fundus? What's the opportunities here?
Sure. I must clarify that IART syndicated for Canon CR2 these and Topcon NW400 cameras. That's in the US. Outside US, we are indicated for over 20 different cameras. The reason there's a difference is because within US, we are, for the FDA clearance, we are required to provide the prospective study. But remember, those really large um, independent studies that I mentioned that had multiple cameras, all these different cameras, let's say your Zeiss or your iCare DRS Plus, um, all these cameras were used, and they did not find any difference in IART's performance across multiple cameras. This has been reported by NHS in their paper as well. So we believe that, and that's what our OUS indication for use is not restricted to these three cameras. It's across over 20 different cameras. I hope that answers the question.
Yeah, so the MDR and CE regulation approved for plus 20 different fundus cameras. So it's only in the US and the FDA approval that is limited to those three. If anyone's on the call need a full list of cameras that we're working with, or INOC is working with, of course, we'll be happy to provide it. A final question for me here, you mentioned countries here where you're active, top reference customers across the world. If you should mention a few, who would you, put to the top?
Sure. I would say, there are different folks who use our technology in uh, different ways. Um, the Temple University from US would be, I guess, one referenced customer that I would mention. There's University of Nebraska as well. Dr. Stephen Ye there would be a great reference. There are there's uh, there are a couple of German hospitals, and I must, I would need, just give me one moment here. while I clarify. Please feel to reach out, to me, or like I can provide you a list there. But I do have, there are definitely a lot more that we can provide.
Yeah, and we can include that also. But if references are needed, of course, we can provide it. We also know quite a few across the Nordic countries have advanced pretty much on both retrospective and prospective studies to do a short local validation before getting into clinical use. Maybe just the last question. There's a lot of focus in screening in general about risk prediction. And in terms of implementing this in a large scale within the DR screening, what's your take on this?
I think it's a great way. Looking at duration of diabetes, looking at HbA1c and other patient data in conjunction with the risk markers that we get from images to determine what might be the risk that this patient would essentially entail for progressing to a severe form of the disease. That's how we look at this. I believe, typically risk is done just based on patient metadata, which is great. I won't take away from that. But the way we look at it is, since we have the images as well, we want to put all those together. But if it's not there, then maybe it is just the patient metadata. We come up with a risk score, and that helps us at least prioritize who are the patients who need to be imaged, who need to be managed, and all that. I think it's a good way to.
Great. I think that concludes the call here. And again, thanks for all of you who decided to spend 40 minutes with us in this webinar. I hope it was worthwhile the time, and especially also thanks to you, Chaitanya, for being so early up in the morning and taking us through this content. We'll share the recorded version and some of the other presentation and elements. If anyone are particularly interested, please reach out. Otherwise, thank you everybody for joining, and have a good day.
Thank you. Have a great day, everyone.